right, hello everyone, and thank you so much for joining us for this fourth and final installment of the webinar series. The series that is the Responding to Domestic Violence and Situational Grief, a primer for mental health and spiritual care professionals. Today's topic is synthesis and Q&A, exploring similarities, differences, complementarities, and resources. And our speakers today, as they have been the last three sessions, are Dr. Claire Bamberg in Vermont and Ms. Dawn Starry in California. Take it away.
So Dawn, you want to start? Say a little bit about you?
Sure, yes. Thank you, Janelle, for the intro. So my name is Dawn Starry. I'm a pastoral counselor working in San Diego, California. For about the last 10 years, I've been working with refugees and asylum seekers and who are primary and secondary survivors of torture, state-sanctioned torture. And in that work, I have come across people who are also survivors of domestic violence. And so that is what I've been talking about in the webinar, and then what we'll cover a little bit more about today as well.
And I'm Claire Bamberg. I'm speaking to you from Vermont. I trained with hospice in 1978. That'll tell us something. And have been working in and out of hospitals, Brigham and Women's Hospital, Children's Hospital, and then in my capacity as a parish minister and church consultant, with topics associated with all kinds of grief. And part of what I've been doing is learning how to teach people what appropriate and healthy grief looks like and what the grief cycle looks like. And in this particular instance, trying to help chaplains and educators understand what best practices are around students and patients when confronted with sudden grief. I also work a lot with first responders. Just want to say, if you have any questions, please use the Q&A. If you find that you have questions after this presentation, please feel free to get a hold of Janelle, and she will be in touch with us. And that includes if you want direct response to anything you may be concerned about. So Dawn and I took a little time just to set some context. I have looked forward to working with Dawn. I have never worked with her before. I anticipated that it would be every bit the wonderful experience that it has been. And we covenanted before we started that we would attend each other's presentations and listen for new ideas, things that were similarities, things that were differences. We actually expected to find a lot more and a lot more deeply divided differences than we found. We spent some time debriefing with one another, and we would like to today, as an opportunity to both review and highlight and open up the floor for questions, some of the things that we've been talking about over the last 3 weeks. I'm going to screen share, and we will take turns jumping in. Probably one of the things that was most remarkable for both of us were the number of kind of upfront similarities. So we each gave you a list of resources that you could take a look at, and we built upon one another's as we were working together. Those lists are available on the YouTube channel, which Janelle will direct you towards at the end of this. So what we're suggesting is that in advance, that is, as a matter of just supporting yourself in the role that you're in, assembling your resources. And I'll just, again, go over what those would look like. So literary resources, research articles, pamphlets that you can lend people. Marie Fortune has some wonderful work that she's done around domestic violence and Christian scriptures. It's a little pamphlet that you can give to people. Cataloging who in the area you might be able to turn to for support, professional support, pastoral counselors, as Dawn mentioned, she's one, I'm one, psychiatrists, domestic violence shelters, For me, it's usually people who can help debrief. Right now, we're working on something in the state of Vermont where we've had to bring psychiatrists in to work with a fire department because of a situation they just went through. So knowing who those are, where those are, and how to reach them. Most communities have a 211 opportunity. Dawn, I don't know if you have one there.
Yeah, we do in California, yes.
Yeah, so 211 is a phone number that you would call, not unlike 911, except the difference is that 211 is information. Some 211s also coordinate mobile crisis units. Mobile crisis units are specially trained individual mobile units that go on and do on-site evaluations for mental health status and critical assessments, and can do immediate triaging. So just knowing what those are in your area. I just want to highlight again, tell people, Melissa Walker-Luckett and I, Melissa is our incoming president, will be developing an assessment tool for educators to use that covers an assessment of where your students are, those applicants that are coming into your programs, where they are in terms of their processing of their own grief or their own triggers around domestic violence or intimate partner violence. If you have insights about that, would you please get those to Janelle so that we can build them into the assessment tool? We'll be working on that, hopefully to roll out by January. Anything else you want to say about this first one, Dawn?
No, I'll just echo what you had said, Claire, that I was very surprised at the similarities, that there were many more similarities than I anticipated between our offerings. No, I don't have anything to add right now. And then somebody did ask, and that question's been answered, but that the slides too will be available as well as the whole webinar series.
Oh, yes. Mm-hmm. Yeah. With the caveat, for those of you who were here last week, that the slide that I worked from, that is the grief cycle, is being reworked. And I can make that reworked slide available as well once it's completed. So Dawn, you want to take this second one? Because we both found this to be really important.
Yes. So center and breathe. I'm often talking to my clients about breathing, and sometimes when that initially comes up, people will kind of chuckle, right? But I think we've been talking about this enough, certainly in the webinar, but also kind of as a society, the real importance of slowing down and really so thinking about that moment where you're either sitting with somebody in a hospital setting or you're sitting with somebody in the educator setting, and they've been triggered or they're sharing with something with you that is upsetting to them and then can be upsetting to you as well. And the importance of being able to just slow down and breathe and then just center yourself. Like I have told people, give yourself a little pep talk if you need to, but whatever kind of helps, like visualization, if it's really just focusing on the breathing, letting your body, making sure your body is relaxed so that you can really access the information and the education that you have around how to respond to people in a way that is kind, compassionate, empathetic, but also effective too. So just the real value in taking that, and that we both recognized that whether it's around grief or it's around intimate partner violence, domestic violence, those are both can be heavy topics, right? So to be able to be fully present to the person that's sharing with you is just invaluable.
That non-anxious presence. If
Yeah.
somebody is triggered or your buttons are being pushed, the most important thing you can do is slow that process down and stay centered and selved. So in addition to breathing, focusing on breathing, if you really find that you've gotten knocked off kilter, putting a hand very subtly on your solar plexus and feeling yourself breathe will bring you back into your body and back into a calmer place. So the non-anxious presence, the kind, compassionate, accepting position is a place from which then it's possible to be genuinely curious. So this is our third point. Genuine curiosity means editing out the tendency that we have as human beings to assume we know. My kids know this. I don't really care to have my name or birth and death dates on my headstone. What I want is this saying, and the saying is, be more curious than certain about what you think you know. Because we're human beings and because we're meaning makers, we often jump to conclusions that actually interfere with our gathering of data and information. So being genuinely curious about whatever may be going on, which leads to assess, assess, assess. And this is a similarity in the process that we would use at this point in time. This will also be highlighted in the differences section, because what we're assessing for in each instance takes us to a different template for assessment. So we'll come back to that. But right now, the process: ask questions, assess, neutral tone, calm demeanor, and data collecting. So where are your resources? Who might they be? If you leave here today, where would you go? Who do you know will be in your corner no matter what? I sometimes ask clients when I'm doing a genogram assessment, when you fell and skinned your knee as a child, whose lap did you crawl in? I mean, it's the kind of figuring out what are the relational assets that people have, and helping them articulate them sometimes makes them aware that they have more than they thought they did. Anything you want to say here, Dawn, about the assessment part of this?
No, I don't really have much to add. Really just echoing again, agreeing with you that just the value of being open. Well, and then I guess what I would like to add is that we bring our biases, right? And our assumptions to a situation. And so the work that we're trying, the offering we're giving to you, and then the work that we do as well, is to put those assumptions aside. And that's where the genuine curiosity comes in, to really be able to hear what is being said as opposed to jumping to conclusions. So the slowing down, the listening. And I just, how invaluable it is, Claire, that you said that. So often people will say things like, well, I have no one, like there's no one that can help me. But when I stop and really try to piece it apart, it does become clear that there are people that are there. Maybe they didn't immediately come to mind because of stress or anxiety, fear, but really piecing that apart with people can help them see the strengths and the resources around them, as well as helping them see their own internal strengths as well.
Well, and in moments of anxiety, it can feel to people like they are all alone when you sit down and say to them, so is there anyone in your faith community? Is there anyone in your school? Is there anyone? So, and then they begin to think outside of the box into which they've put themselves. Mm-hmm. And yes, in fact, they have resources.
Right.
Maintaining a non-anxious presence is the thing that we really talked about in the second similarity, that part of the whole point in doing this series that Dawn and I have committed to is giving you the cognitive concepts, the literal resources, and ability to assess for resources, and some of the questions to ask yourselves and one another that will, we hope, increase the likelihood that if you are suddenly blindsided by one of these circumstances, you're actually going to be able to attain and maintain that non-anxious presence. The other thing that both of us really stressed is the physical boundaries aspect of doing this work. Again, not only are we meaning makers and we jump to conclusions and edit and, figure, well, that means thus and such. We also are tender-hearted people. We wouldn't be in this profession if we weren't. And the impulse, and the culturally supported impulse, to reach out and comfort another physically is not to be overly dramatic, but it honestly is one of the worst things you can do in these situations. You don't know what somebody's experience is around touch, and particularly with domestic violence and intimate partner violence, also in grief, because you don't know what their history is in terms of their relational history. Not touching without express permission. So it would sound like, may I touch your hand? One of the things I also talk with people about is if there's an impulse to incline towards or touch someone, again, if you're a hospital chaplain or in a room, you can put your hand on the bed next to them. If you're sitting up close to the bed, just don't touch them, right? And even then I would ask permission. Is it okay, Dawn? I think one of the things we talked about with you is it okay if I, touch your arm? Is it okay if I put my arm around you? Would it be comforting if I offered you a hug? Those kinds of things. So always, always, always not only check out the welcomeness of a hug, but also be very specific about the touch that you're offering. Anything else?
Well, I wanted to say too that sometimes this idea that it is supported culturally that we should hug in times of difficulty, or we should touch in times of difficulty, and that for some people in that level of stress, like actually and not even necessarily because there had been like a history of sexual assault, or there had been a history of a violation around touch or physical boundary, but some people just don't feel comfortable in that moment, and so then to be shamed or chastised, and I've heard stories like that, where a partner feels sort of neglected because they wanted to hug but the other partner didn't, whereas it's not a personal matter, like as a way to insult the other person, but that some people need that space to sort of make sense of the situation. So that's why it can really, it's just important to ask that question to make sure everybody's feeling like they're on the same page. And then thinking about clients I've worked with or the patients you work with, like if you reach out and touch a person without asking, I think at least certainly with the people I work with, I think they would feel obligated to keep their hand there, even if they didn't want to keep their hand clasped with another person. So to be able to have that empowerment of being able to say no or yes, thank you, is so important for people, especially in those critical high stress moments, really in general, but especially in those moments, I think.
I think the other thing that we didn't list here, but we both found, is if somebody says no to you, one of the most important things a caregiver can do is not take that personally.
Right.
Right. So having to allow touch out of obligation is not healthy in any aspect of our culture. Mm-hmm. So we want people to feel empowered. We want them to be able to say no, and we want them to we ourselves need to understand that's not anything about us. They don't know us. What they know is whether touch is comfortable or not. That right. They know. And then finally, in terms of the similarities, and we each spent quite a bit of time on this, is the necessity. This isn't advisability. This is necessity of your own assessment of yourself. What's my history with this? How do I react? How do I respond? What resources would I have if I was in a similar circumstance? How would I know how to find them? Who would I turn to? Where would I go? What are the therapists in our area or pastoral counselors in our area that are trained in this way? And then to do some self-care. I just came off a weekend training for a volunteer pastoral caregiver group. And one of the things I really hammered home is you don't go on a visit if you're exhausted. You take the time to go for a walk in between patients if you've had a really tough visit. You eat healthily. You wait outside the room and kind of center yourself before you go in. These are all ways of taking care of yourself that, in addition to taking care of yourself, lends itself therapeutically in the system of being a chaplain or being a first responder or being a pastoral counselor in that situation. Anything, Dawn? Anything more? Okay.
No, I'm nodding my head because I am in full agreement to everything you just said. Yes.
I think we're going to be doing a lot of that.
Yes.
Again, a reminder, the people who are online, first of all, thank you. We're pleased that you're finding this valuable. And secondly, please use the Q&A feature on the Zoom toolbar, and or realize you can get a hold of Janelle to get to us if you think of questions afterwards.
Perfect.
So the differences themselves, some of them are pretty overt. Dawn, I'm going to let you start this for this one, and then I'll jump in.
Sure. And so the example on the slide is the refugee on the street versus the patient confined to a bed in an institutional setting. So I had given the example in 2 weeks ago about having been with a client literally walking down the street with her and an interpreter. And that then she came out and told me about an incident that had happened like within a day or two before, where her husband had physically harmed her in front of their children. And so most chaplains are not going to find themselves in that situation, right? Either, for those on this call, it's either going to be in an institutional setting or in the educational setting for the ACPE educators working with students becoming chaplains. So that was, and well, I'm trying to think too. I mean, I think in general, most people are not going to find themselves in a situation where I was, though some people do home visits as well. So there is that contextual difference that comes up between the work that was being done with my work with refugees and asylum seekers versus sort of the traditional settings of chaplains and chaplain educators.
Yeah, so part of it is the part of the context is location. Part of it is whether the conversation is voluntary or not.
Mm-hmm.
So perhaps in my case, I was an expert witness in 2 counties in Indiana, and I would sometimes get court-ordered people in my office as clients. That's a very different kind of work. Visiting someone who's confined to a hospital bed in an institutional setting or in a nursing home brings a whole different power differential into the equation. And so, adjusting for that, as opposed to somebody that you're walking with on the street and could voluntarily walk off if they want to. Mm-hmm. So it's adjusting how we're present to allow for the space to be safe enough for people to explore and go where they need to, because in any of these instances, what they're doing is exploring out of a place of vulnerability and not knowing and disorientation and loss. And so we want to take into account the context in which we are encountering the individual and make adjustments for how we're present in those contexts. Quite different in some of the circumstances. People who voluntarily walk in my office do, present themselves in a whole different way than people who are court ordered, for instance, or whose parents bring them to be fixed, quote unquote. The other difference that we found is around reporting mandates, and I just learned this over the weekend. So the reporting mandates that Dawn and I ran over with you vary state to state. In California, you're required to report if you have reason to believe somebody's being neglected and abused up till 18 and at 65 and older. That is not true in Massachusetts. That is not true in New Hampshire. So every state has something different. And in fact, in Massachusetts, you're not mandated to report elder abuse at all. So check your verbiage, check your state statutes, be sure you represent accurately the legal nature of this. Having said that, what we do all have is a moral responsibility to one another to ensure safety, particularly when we're entrusted with a client, whether or a patient in a hospital. So just get your language clear. Set some policy statements within your department or in your program, and be sure you're accurately representing the legal requirements of your state and whatever policy decisions your department makes or your program makes about reporting requirements. Did you know that, Dawn?
About elder abuse?
Yeah.
No, I didn't.
It's been an interesting weekend for me, let me tell you.
I just assumed it was all similar. I did want to add to that too, though, where certainly agreeing with everything that you're saying, but also saying, you know, you in California, you have 24 hours. Like, I find out some information, I have to report within 24 hours. Mm-hmm. And that thankfully gives me time to sort of assess the situation, to talk to, in my case, my clinical supervisor and anyone else, to sort of, not because I don't want to report, but making sure that I'm also taking care of the needs of the client as mm-hmm. well, like how mm-hmm. to handle that in the best way. Because I said that incident, I knew that I was going to lose that client by reporting, but I certainly was going to report, even if I wasn't mandated to, because of the nature of the incident. So taking that time, and I have also called Child Welfare Services. I have not had incidents yet, hopefully never, around elder abuse, but I have called Child Welfare Services and said, okay, here's the situation. What do you think? Mm-hmm. So that it's really okay to ask and mm-hmm. to get as much support as you need. Mm-hmm. Again, not to blur any lines around the legal lines. I in California mandate it up to 18, 65 and older. And then if there's an active threat of suicide or homicide. So I know those rules, but that I have some space to call the people I need to in order to handle a situation. And I had a situation like that just a couple months ago where it was like 2.5 hours, a teenager who was threatening, when she was having psychotic features around harming others. And so I was on the phone with, like 5 different people, and that's okay too. And then I tap into the self-care. But it's just so there's space to talk to the people you need to talk to.
Right, and in most states, it's not, you are not required to report immediately. You do have a time frame.
Right.
And this is why I'm saying, as a program or an educational program, set a policy, talk about these things with your students, understand what the parameters are state by state. Some institutions have their own requirements. Check if yours does, and talk about it. So people, again, this is another thing. When you've got the information, you know what your resources are. Mm-hmm. You've done the self-care. You've done the personal inventory around where your triggers are. You walk into a room with confidence. You are going to be that non-anxious presence that people so desperately need when they are either triggered unexpectedly or have this very vulnerable information they're being asked to share. With the third one, the resources available, this again, if you want to create a checklist around your assessments that you're doing, this would be a place to start. What are their family resources, both nuclear and extended? What are their financial resources? Some women in particular stay in violent relationships because they don't believe they have the resources to get out of them. Or if they did, they don't believe they would be able to take care of their children. I think that's fair to say, Dawn.
Absolutely.
And then financial resources too. I've lost count of the number of people who have said to me, well, I don't seek professional help from a mental health professional because I can't afford it. Mm-hmm. There are sliding fee scales, there are state programs, there are tons of ways to get people help. One of the things, again, Melissa Walker-Luckett and I are doing, in addition to the assessment tool, is compiling a list of the vetted former AAPC psychotherapists, pastoral counselors, certified pastoral counselors in geographic regions. And to the extent that we can, we're going to document their professional strengths. So if somebody's works a lot in grief, or somebody works a lot in family systems, or somebody, you know, that you'll have that list, those of you in programs, CPE educators and chaplains, because discharge planning, whereas in Dawn's case, there is some follow through. She's going to be able to follow up with people. When we put our heart and soul into a moment with a patient in a hospital or an institutional setting and they take off, often the relationship is just severed unless they're readmitted for some reason. Being able to give people the resources that when they leave, you've done due diligence around giving them the information to get the support to continue the aftercare that they need is going to be incredible for people. What are their community resources? Do they have a faith community? Do they have a network, a social network outside of the home? If so, what does that look like? State and local resources, funding. A lot of towns and municipalities have a town-appointed social worker or mental health professional, marriage and family therapist. Those are also meant to be resources for people who are financially insecure. That goes right into professional resources. Others, Dawn, that you can think of?
Well, the one that comes to mind for me, in at least with the hospice care in San Diego, there are several of the hospices that offer grief counseling for free.
Yes, and support groups, both.
Right.
Yeah. So you know, also very specialties. Somebody asked very early on about fetal demise. There are also within hospice very specialized support groups around neonatal loss, fetal demise, in addition to the traditional kind of support groups around widows and widowers and the year beyond the loss, year to year and a half. They're open-ended for the most part, and they're run by people who are well-trained and whose hearts are in the right place.
Well, and I did want to add too, faith communities in general certainly can be very helpful, but also I know in San Diego, both the Episcopal Church and the Catholic Church have those resources, like are prepared when a person calls to refer them to somebody. So that the larger faith community might actually be tapped into ways to connect people beyond, the support that they receive when they, enter a place of worship, but, even professional resources as well.
Yep. So I talked earlier about one of the differences that we were coming up with was the content of the questions asked, so specific circumstances. And I was driving today, I was thinking, how do I describe this to you? So I'm going to try to do this in levels, and I'm going to ask you to jump in, Dawn. So in mental health, many of you will have run into this. We learn that people operate at different developmental stages regardless of their chronological age. So almost innately, those of us who are in helping professions kind of adjust for what's their cognitive acuity, vocabulary. In Dawn's case, you may need an interpreter sometimes. And so part of the assessment is going to be around the capacity of the other to take in what we're trying to say or offer them, and what we have to adjust in order to be able to do that. So in Dawn's case, and this is true in chaplaincy too, depending on what part of the country you're in, sheer vocabulary. Like, do you speak the same language? If not, getting an interpreter may or may not mean you get someone who actually understands the psychological nuances of the work you're trying to do. spend some time cultivating a relationship with interpreters where you can bring them on board so they can help and function better on your behalf and your patient's behalf. Other stages or other questions that you ask refer to specific circumstances. The questions Dawn's going to ask around evaluating for safety and resources are going to sound different than the questions I'm going to ask around grief and support around grief. So Dawn, can you, let's play with that a little bit. Some of the ones that you have to ask that would be clearly different than what I would be asking.
Well, certainly well, safety can play into both, but thinking about the idea of who can a person reach out to, and creating that safety agreement. There's a different word for it, but I'm blanking. And writing it down, like, where are the numbers you can call? Who are the people you can go to? Is there a place that you can go to? So I would imagine that's going to be certainly different than if you're working in instances of grief.
Mm-hmm.
So that's the first thing that comes to mind.
In instances of grief, again, it depends on context. Is this someone who's lost someone out in the, in their nuclear family? Do they have a funeral home director? Is there a program for them? And then there's the safety issue. So one of the ones that you alluded to, Dawn, is who can you go to? And then I would just add the word safely. Who can you safely go? Let's assess for safety. In my case, it would be, who can you go talk to? Who can you go talk to who's going to understand what it is you're going through? In our culture, we are very quick to invite people to quote unquote get over it when what they're dealing with is grief. I think I mentioned last week, if I didn't, shame on me, that when they created the most recent Diagnostic and Statistic Manual, they made bereavement pathological after 2 months. That is our culture, folks. And I'm sitting here and I'm telling you that done well, the grief cycle, moving through it well, takes a year to a year and a half, up to 2 years. So helping people understand that, no, they're not going to get over it. First of all, they're not going to ever get over it. They'll get through it. And understanding that going to people who really understand how to support people through this is going to be in their best interest, not to somebody who's going to tell them they're losing their mind if they're still grieving in 3 months. I mean, that's a little dramatic on that end of the spectrum, but you understand what I mean. So the context of the question to ask in both our disciplines are reflected by the specific circumstances in which people find themselves. Dawn, I'm seeing there's a Q&A, but I can't open it. Can you get that?
I opened it. It's a question, or more of a comment, but in the case of chaplains, it's important to consult/work with social services people rather than take on such issues as abuse by oneself.
Yeah, that can be the case. And if you're lucky enough to have an opportunity to work with someone that you can see it coming, what we're trying to address is the circumstance where you don't see it coming. You maybe don't have the time. It's after 5 and you're making a visit and the social services people are gone. We just want you to have a context for assessing best practices and then self-care after the experience. So thank you for lifting that up. Yeah, it's nice to have those resources in-house.
Right.
And just to piggyback on that, and knowing which of your social services people get it. Not just because somebody's in social services doesn't mean they necessarily have an affinity or an understanding of this work. So be choosy. You can afford to do that. And that's an element of your own self-care. Commonalities, the things that we would both stress that you gift yourselves. We are going to get that assessment tool for educators. There is going to be an element of self-assessment for clinicians. You're going to need that to be assessing for students you take into your program. We want you to have referral resources. Dawn, maybe you and I could work on a little bit about what that would look like beyond 211 for people who are, suddenly encounter domestic violence or intimate partner violence.
Right, absolutely.
And we want you to have an annotated list of professionals in the area who can support you both in the work that you're doing, in learning more about this, and supporting you as you learn more about this, and for you to provide resources to those that you have seen and they're being discharged, or you have seen and their DRGs have run out, or you have seen and they're at threat of disappearing, as they do in Dawn's world. Anything you want to add, Dawn?
Well, I was thinking about the comment too that the person made about knowing who to talk. Well, you said knowing who to talk to, but that they said, not handling a situation like abuse alone. And I think that assessment piece is so important, as well as the policy, as you mentioned.
Mm-hmm.
People know who, like, it's very clear that people know who they can go to, who they need to go to.
Mm-hmm. And it would be, if you did a self-assessment and realized you had a vulnerability around one or another or both of these topics, you absolutely would not want to handle it alone. However, our training means we absolutely do. I mean,
Right.
We're going to be handling this alone in 8 out of 10 cases. So what we're trying to do is give you some of the tools and supports for if you get stuck, you know what to do. Fair enough,
Right, so you don't just shut down. Yeah, so you don't just shut down and do nothing. Right.
Yeah, right. Or fall apart, which is, one of the earlier cases that we were given. And the other thing is, there are personalities with whom you click. There are expertise that are supplemental to what you can offer. Get to know your other staff. What I love about the suggestion that was made and the reminder that was offered is that we aren't in this alone, or we don't have to be. And part of what the gift is that we give ourselves is figuring out who can we partner with in specific circumstances. Right. The other thing, this is number 3 on this one that has come up again and again. So I mentioned in Scottsdale and in the course of this webinar series is that these aren't things that are taught necessarily in chaplaincy programs, which is part of what you all are lifting up. Like, wait, we don't have an assessment tool for this. So what we want to do is be sure that in the wake of this series, in the wake of these workshops, we're giving you an opportunity to increase your sense of being informed, of knowing what to do, not only in competency, but also in presence. And we want to be able to give you the support that you need going forward to be present to your students, as well as helping them be present to their patients, as well as providing support for pastoral counselors who run into this as well, or the first responders that I work with. Anything you want to jump in?
Just that it's so critical to have, just so critical to have, and have people to talk to, and have supervision continuously, even after many years of doing this work. Just to be able to have people to talk to.
What a wonderful reminder. Debrief, 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 debrief. Mm-hmm. You will burn out or decompensate if you don't do the aftercare for yourself. Mm-hmm. Though you may not yourself be a first responder, you just to lift up, it is a psychological fact that secondary trauma is trauma. Right. And the need to debrief is incumbent upon all of us in the helping profession. Okay, so we have some questions just for you to consider. Again, the resources are listed in our separate presentations. We can do an annotated bibliography at some point if that would be helpful. What are you taking with you from these sessions? Where are you going to go with this? Please don't let this be the end of your journey. Our hope is that this will open a door for you to consider these topics and do some self-assessment, assess your programs for how you help your students in these areas, figure out what additional resources you may need, and let us know if there's anything we can do to help you with this. Often when people think about moving into a new area of study, they get overwhelmed. Just do a small next step. Who could you look up in your phone book, or who could you talk to about in your clinical setting that they would say to you, oh, I know this person who, what would a small next step be for you, Dawn? Like, what would people do?
I think what I would encourage is really looking at the resources and choosing one to
Explore.
Yeah, one to explore and to dig into a little more deeply, and to maybe even do a little research around, well, I think we actually offered plenty to start with, to go to that list that were offered before, and just to kind of explore and educate oneself a little bit more.
Okay. And then this is for the educators and for the people who are in charge of programs. What goals have you or will you set for yourself and your programs in the wake of this work, in this series? What have you learned? Where can you tweak things? Where are your strengths, where things you're doing really, really well, and where are your growing edges, and how can you strengthen those aspects of your programming? How can we help? How can ACPE help? Is there a community of practice you can join? Which brings us right to number 4, to whom can you turn for further resourcing? And then finally, I'm going to suggest, and the people on this call can be in touch with Janelle if this is something of interest, that perhaps there is a community of practice that is initiated for clinical supervisory concerns in any number of this areas in which students can be triggered, and you're not sure what next to do. We've talked about peppering some of the COPs with some of the AAPC people, and this would definitely be one of those places where a collaboration towards excellence in programming would be a no-brainer. I mean, I really think we could do well around this. Anything you want to add, Dawn?
No, I love the idea about the community of practice. Offering that space is so important to be able to talk about these things and the questions that come up, the very many natural questions that come up. Yeah, I don't have anything else to add at this point.
Okay. So we're going to pause for a minute. We have about 10 minutes left. If there are any questions that come to you right now, please take advantage of the Q&A on your toolbar of the Zoom presentation. And we'll wait a couple of minutes to see if people have that. And if not, Janelle would like a few minutes of your time. I want to remind you that though the webinar series itself is closing, Dawn and I still exist in the world out there and are willing to be contacted. Please use Janelle to get through to us. It gives us a little bit of a heads up about what you might be looking for, so we can plan an articulate and researched answer for you, or know if there's something around which you want to collaborate, kind of have ourselves ready for that. Any questions? Okay. Oh, yep, there is one. You want to take that, Dawn?
Sure. What resources would you recommend for a CPE student who has blocked traumatic experiences and it is affecting their competence?
Well, in general, I probably would push the pause button or invite them to and get some professional help. There are people who have expertise in trauma-based work. Dawn's recommended Judith Herman's book. We wouldn't necessarily want the student to read that, by the way, because they could be re-triggered just in the reading of the book. We would want them to feel not alone in the journey they're about to take, because it will be very difficult. So I would say probably the most important thing would be to get them to a therapist. There are, depending on the type of trauma, There are also companion books for people around specific topics. So if you have a topic, a specific topic, you want to take this offline, let me know. There are some books I can recommend in some areas. But in general, I would get them professional help and guidance.
That's what I agree with that. I would do the same.
Anyone else? Okay, Janelle, do you want to jump in?
All right. Well, thank you everyone for joining us for the conclusion of this 4-part webinar series. And a special thanks to Dawn and to Claire for sharing with us your time and your experience and your insights on these very important topics. For those who are tuning in, just a reminder and then 2 quick updates. The reminder is that each of these webinars have been recorded. Presently, you can access the webinar recording for the first and the second in this series. The third will be available by Monday, and then we'll work on this one for the following Monday, the 10th. And the link to that is simply to just go to our YouTube channel, and that can be found on ACPE's homepage at the bottom of the website. And these will be the first ones to pop up. But the link to these will also be included in an update in This Week at ACPE Monday weekly newsletter. And then in terms of just two announcements, one is that shortly after this, we'll be sending out an online evaluation form. And we really do ask that you take a look at that and you share your thoughts, your feedback, and then also your ideas. As you might have seen in one of the recent newsletters, we are getting going with a new continuing education task force. It's one of the fruits of the consolidation. And we would love to hear, what are some other webinar series that you think you would benefit from? So please do take a look at that and respond at your convenience. And then finally, while right now, unfortunately, we are not able to offer continuing education units for this series, we're in the application process so that going forward, a webinar like this could have a continuing education credit for those of you who are licensed. And so if, while we can't give those credits out for this, we can still do a certificate of attendance, and you might be able to submit that to your particular board, just depending on which state you're in and which license you have. And so if you're interested in getting a certificate for your participation in this, you will receive a second form to fill out in that email that will be coming shortly after this. And that's all I have in terms of announcements. And again, don't hesitate to reach out to me. I really am happy to serve as a liaison with other staff members and then with some of our guest presenters like Claire and Dawn. And just one final time, my email is janelle@acpe.edu, and that's just JANELLE in case you need me. All right, so that's all I have. Thank you again.
Take care, everyone.
Thank you.
Thank you.
Goodbye.
Bye-bye.